Good afternoon, everyone. It's Michael Jr. here. We have a few cases, mostly soft tissues. The first one is 82-year-old gentleman with a tumor on his thigh. I'll start with this slide. Scanning magnification. So all you can see is a myxoid soft tissue lesion. On higher magnification, you can already see that this is something obviously pleomorphic, something that has prominent vasculature. You may wonder if this fat tissue is normal or abnormal because the pleomorphic cells are also in the fat tissue, but it's unclear whether these are tumor cells infiltrating fat or abnormal fat cells. And again, here the pleomorphic cells scattered throughout the tumor. You will find increased mitotic activity, including atypical mitosis. So this is most likely a sarcoma. Pleomorphism by itself isn't enough to call something sarcoma, but when there are atypical mitosis and a high mitotic activity, that's already quite convincing for malignancy. If it's coupled with necrosis, it's almost certain. So here, I don't recall if there was necrosis in this case, but definitely high mitotic activity, pleomorphism, infiltrative growth. And with this morphology, notice the thin-walled arborizing vasculature in the background. In the center, for example, here. This is quite illustrative case of anybody has some guess? Old guy? Exactly, this is myxofibrosarcoma. It's a prototypical case, that's why I brought it. It's one of the most common sarcoma types, typically on the extremities, especially on the thigh of older people. And it's one of the most common superficial sarcomas. It's very often superficially located above the muscle fascia. So apart from calling myxofibrosarcoma, you should also call or give it some grade 1, 2, or 3. The grade 1 tumors are very bland. They are sometimes difficult to distinguish from intramuscular myxomas or some benign lesions. So this is definitely not grade 1. So here we are differentiating between grade 2 and grade 3, which is based on mitotic activity and presence of necrosis. For this, I recommend everyone to look in the book what's the cutoff and then just count the mitosis, look for necrosis. This was eventually called grade 2. And yeah, although even if they are grade 3, they have relatively good prognosis because they are superficial. They can metastasize, but it's not as often as you can see in, let's say, undifferentiated pleomorphic sarcomas. So myxofibrosarcoma grade 2. The next case was a 65-year-old male he presented with 15 centimeter large lesion in his axilla and widespread metastatic disease, including in the lungs, both lung hilli, then metastasis in his liver, adrenals, and mesentery. So we had samples from several of these locations. Most of them were really the tissue was damaged, was hard to read. This was one of the better samples. Straight out, you can see this is largely necrotic tumor. I don't know from which location this is. Doesn't really matter. One of the tumor lesions. And so widespread necrosis, and then some round cell or epithelioid neoplasm. Let's look at some other slide. Maybe there was something better. Okay, here maybe. So the tissue is really smudged, but here at least it's not necrotic so much. So you can see it's very cellular, very hyperchromatic. It's generally hard to say something more than that. So you're kind of stuck with differential, undifferentiated neoplasm. This could be undifferentiated carcinoma, undifferentiated melanoma. Definitely, this could still be some lymphoma, small round cell tumor, of course. But then you start basically immunophenotyping. So you use broad panel, some lymphoid markers, some broad spectrum cytokeratins, S100, SOX10, Desmin. This would be, I think, reasonable panel to start with, and this is SOX10. So pretty nicely positive. S100 was similar. A little faint here, but there is some positivity. Next immunohistochemistry was PRAME. Again, PRAME is not a diagnostic marker for melanoma, but hold on, this is probably, yeah. It's not a diagnostic marker. That's the lung lesion probably. Not a diagnostic marker of melanoma, but if this would be negative, it would be highly unlikely that this is melanoma. But with PRAME positive, it can be still many things, but melanoma is still included in the differential, and given S100 SOX10 positivity, it's very high on the list. Tyrosinase HNB45 was negative. I also did MITF because it's like the most sensitive marker, but the least specific of monocytic differentiation. There is some MITF faint, I don't know if to call it positivity, so this is not helpful. But in any case, this is highly suspicious of melanoma. If the patient had a history of melanoma, the diagnosis would be done, but there is nothing, we don't have that information. And so we did molecular analysis, and there was NRAS mutation and high mutational burden, tumor mutational burden, and also UV mutational signature. So this is definitely melanoma, which is at this stage of disease the only little good news for the patient, because he still has a treatment option. Even that advanced disease, when he will get immunotherapy, he has a chance to at least have a prolonged survival. Even patients with such a really advanced disease react very well. So one more perhaps useful thing is that we have a RAS and BRAF antibodies, which can detect the most common BRAF and RAS mutations in melanoma. Unfortunately, the RAS immunostaining was negative in this case, which is because this specific mutation that was in the tumor NRAS Q61K is not covered by the antibody. It's about 1/4 of the NRAS mutations is this specific one. So in these cases, RAS antibody will be negative. Okay, next quite common case, old 83-year-old lady, tumor on her face, skin lesion, and so you can see skin excision with solar elastosis, very prominent solar elastosis, so marked UV damage. Then epidermis, which is kind of flattened, but it's hard to say whether there is some atypia or not. Looks relatively normal, but then in the dermis, right beneath the epidermis, you can see again quite polymorphic, very cellular tumor with quite high mitotic activity. And so what should we do now? So this can be a couple of things. The differential definitely includes some melanocytic lesion, especially melanoma, sarcomatoid carcinoma, some smooth muscle tumor, although unlikely, but it's good to stain for it. So you do a basically broad immunohistochemical panel, cytokeratins, SOX10 S100, I do P63, H-Cal Desmond. This is a good panel to start with. Everything was negative except for P63, which showed this focal weak positivity, which is quite unhelpful. So here we are stuck with a differential sarcomatoid squamous cell carcinoma and atypical fibrosarcoma, because the lesion is very superficial and mostly immunonegative.
There is high-grade dysplasia in the epidermis, as I saw very quickly.
Yeah, but this is well described in atypical fibrosarcoma as well, so it's not really helpful. You know, the methylation studies have shown that basically sarcomatoid squamous cell carcinoma and atypical fibrosarcoma have very similar overlapping methylation profiles, so it's probably a variant of the same thing.
But these typical fibrosarcomas, so-called, are nothing else but sarcomatoid carcinomas as well. Those having dysplasia in the epidermis.
Yes, that's your opinion, but in the literature,
I'm sure of it. Yeah.
Yes, that doesn't mean anything though for the general public. Yeah. So I'm saying what's in the classification and how we are classifying things. So atypical fibrosarcoma by definition is basically this. If you call it superficial sarcomatoid squamous cell carcinoma, nobody can tell really. I think that you are incorrect, because at the end there is focal P63 positivity as well. Both have very good prognosis. Basically, if this is completely excised, which is, it will not recur. You have to also exclude lymphovascular and perineal invasion, which is not here. So this is really, if completely excised, this is cured. So atypical fibrosarcoma or sarcomatoid squamous cell carcinoma, whatever you choose. Most important, exclude non-acidic lesion melanoma, because it can look pretty much the same morphologically. So next case, 44-year-old lady. She has a tumor in her psoas muscle, and based on CT scan and clinical examination, it's suspicious for sarcoma. We have a few of these punch biopsies. So here, indeed, some quite cellular spindle cell tumor. Maybe there will be one more. Yeah. Slide. It's better. Spindle cell lesion, collagenous stroma. Maybe mild atypia, but at most mild atypia. So any differential in the psoatic muscle? 44-year-old lady. We should definitely exclude dedifferentiated liposarcoma. The patient is quite young, but still, we should test for MDM2. That was negative. Then we should test for smooth muscle differentiation. Smooth muscle lectin, Cal-Desmond, Cal-Desmond were negative. Those are the more specific. The least specific is smooth muscle actin, but it's, as usual, least specific, but the most sensitive. So there is positivity for it. And in this constellation, spindle cell lesion with mild atypia, smooth muscle actin positivity, Desmond, Cal-Desmond negativity, especially in younger females. Think of one diagnosis. Anybody has a suggestion? So this is beta-catenin. Which is, as usual, hard to read. There is always cytoplasmic staining, as in the vessels here. The vessels show like a wild type staining. But the tumor cells sometimes show, it's called nuclear translocation or expression in the nucleus, which is shown here. quite convincing. So this is confirmative of desmoid fibromatosis. You can also do another marker, LEF1, which we show here quite often, which again shows, this is a nuclear marker, so it shows nice convincing nuclear expression. So LEF1, one more thing, always exclude GIST, so DOG1, CD117, also important with this morphology. So looking back at it, this is desmoid fibromatosis. Sometimes it's difficult diagnosis, especially with punch biopsy. Okay, this is a tumor on the back of an 81-year-old male, older guy, and so without much looking at it, you can see something quite malignant looking, very cellular. There's a lot of atypia, especially these scattered hyperchromatic large cells. Again, mitotic activity, including atypical mitoses, are there as well. I'll try one more slide. This was a several centimeter large tumor, so we had a good sample. So this is some poorly differentiated neoplasm. You can, based on morphology, you can exclude anything hematological, I think. It's very unlikely. And you are stuck with some sarcoma or definitely melanoma. The tumor cells have quite prominent nuclei in some areas, not here really, but in others. Nuclei were very large, there was high mitotic activity, so definitely melanoma. Given the frequency is a high on the list. So sarcoma melanoma, theoretically undifferentiated carcinoma, but it doesn't really look like it that much. So again, some immunophenotyping, some basic panel, cytokeratins, S100, SOX10, Desmond, Carl Desmond, because leiomyosarcoma is very high on the list. CD34, MyoD1, because some pleomorphic rhabdomyosarcoma could be in the differential. I did also STAT6 because solitary fibrous tumor can look like anything, although given the scattered atypia, it's unlikely. And very important, even in peripheral soft tissues, is this marker. Let's control, sorry. Any guess what this could be? Which marker is this? The large cells are positive typically. This is MDM2, and MDM2 amplification was confirmed by FISH. So this is, and everything else was negative. So this is compatible with the differentiated liposarcoma on the back. Unfortunately, there is no nice remnant of fat tissue, well differentiated component, but it's not necessary for the diagnosis. So it's quite important to get this diagnosis because although it's a high-grade sarcoma, dedifferentiated liposarcomas have a better prognosis than undifferentiated pleomorphic sarcomas or leiomyosarcomas. So without the MDM2 detection, we would call this undifferentiated pleomorphic sarcoma, which is very high grade, very aggressive tumor. If you think of doing MDM2 and are able to track down the amplification, you basically inform the patient that the prognosis is better. Dedifferentiated liposarcoma. Again, you should count the mitosis, look for necrosis, and basically do the French system grading, typical for sarcomas. Okay, last case for me is a 70-year-old lady who had what's called recurring lipoma on her abdomen, in the skin of her belly. And this was interesting case. I think they probably didn't sample the tumor tissue before, and they just sampled the fat around it. So here's the skin, you can see some fat around it, and they probably didn't remove the tumor before, because otherwise I don't understand how they could have called it lipoma before. But here is the tumor. And looking at low power, it's very cellular, there's a lot of pleomorphism. You see these large hyperchromatic cells. Cells have quite abundant pink eosinophilic cytoplasm. And on high power, you can see it's a little bit like a granular or kind of very fine pinkish cytoplasm. And this constellation of features, a lot of pinkish cytoplasm and scattered pleomorphism, for me was suggestive of pecoma. So I was testing for pecoma markers, which is basically a combination of melanocytic markers, HMB45, tyrosinase, melan A, and smooth muscle markers. Typically, smooth muscle actin is positive, so this is smooth muscle actin. It's as diffuse as it can be. But also the other smooth muscle markers are positive. This is cathepsin K, carlismon, and desmin look the same basically. So I won't be showing desmin, which also brings in differential when you see such a diffuse expression of smooth muscle tumor. Unfortunately, tyrosinase, melan A, HNB45 were completely negative. Then we have other markers of pecoma. This is the new marker called GPNMB, which is typically positive in pecomas and other tumors with TSC1, TSC2 mutations and TFE3 fusions, which is seen in pecoma, or these translocation renal cell carcinomas. So this is diffusely positive in the tumor, and this marker should be positive in leiomyosarcomas. We also did genetics to find the TSC1, TSC2 mutations, which are commonly seen in pecoma, but it was not there. There was just TP53 mutation, which is often in pecomas, but it's also often in leiomyosarcomas. So it was the differential we were stuck with. I think the morphology doesn't look like leiomyosarcoma that much. It's more pecoma-like. And also we did methylation analysis. The tumor didn't cluster with leiomyosarcomas and was kind of overlapping with the pecoma group, although from what I've learned, the pecomas don't form one single group in the methylation classifiers, but by visualization it was elsewhere than the leiomyosarcomas. So, given the morphology, the immunophenotype with the GP and MB expression and the methylation features, I will call this pecoma. So that's it from me. Thank you.
Just us two, yeah?
Ještě Natália.
Yeah, I have 2 cases.
Okay, come in.
Hello, this is Natalie, the resident. First, I have an older case from a 57-year-old male patient who had a lesion in his rib. On imaging, they saw a destructive lesion, something that was infiltrating into the surrounding tissues, so they were suspecting chondrosarcoma. But when we look at it, looks a little different from chondrosarcoma. It's composed of this immature cartilaginous matrix, which is more eosinophilic, not really blue like normal hyaline cartilage. We can see the extension into the soft tissues very nicely, but it's more pushing, not really infiltrating. And let's look at the cells. round or ovoid. Sometimes we can see that the nuclei are a little cleaved. Let's see. Here and there, maybe you can hear in the middle, I think. Yeah. And cleaved nuclei, immature cartilage, that maybe tells you.
Sorry, where was this again?
In the rib. Could be something else, maybe could be chondroblastoma, even though the clinical presentation is quite unusual in the rib, although it's not impossible. Older guy, we should see chondroblastomas in skeletally immature. This was a 57-year-old guy, but we solved it with molecular genetics. We tested for H3F3A and B mutations, and the B mutation was positive. There was a substitution in the protein position 36, lysine exchanged for methionine. So we had a diagnosis of chondroblastoma, and we looked around and asked some experts as well. I think it was consulted with Raoul Perret, if I remember correctly, and they told us that in flat bones, such as rib and others, you can see this pushing extension into soft tissues, and it's fine. It doesn't mean it's malignant, it's still chondroblastoma. Also here confirmed by molecular genetics. We don't really see the typical chicken wire calcification, but we don't have to see it in all cases. Actually, I've only seen it in one case. But there was this grungy kind of calcification here and there, dystrophic calcification. All right, it was my first case. Do you agree with our diagnosis? I hope you do.
Sure.
And the second case is fresh. It's a 46-year-old male patient. Why is it so small? All right. And he has a history of something. I'm not going to tell you what, but it has to do with lymphoid tissue, of course. And over the last 5 years, we had repeated sampling of some lymph nodes because they seem to be enlarged. But always we just saw follicular hyperplasia. You can also see some fatty atrophy. So here it's fine, but look, suddenly we are losing the normal architecture. The architecture is still nodular, but the nodes are much less defined. They are not normal follicles with germinal centers. And here and there, you can see the net of the follicular dendritic cells, such as here. They are proliferating, and it looks like they are eaten by moths. We call this moth-eaten pattern. And maybe from this magnification, you can already tell what it is. We have a node-in-node architecture, meaning we have residual normal lymph node, and inside we have this lesion and this
HIV?
moth-eaten pattern.
HIV?
No. He's negative for HIV. It's actually a lymphoma. When we look closer at the cells, you can start to see some atypia. See these single cells with very large nuclei and nucleoli, and around them we see a sort of lymphocytic rim rosette created by lymphocytes. These are typically follicular helper lymphocytes, which are positive for PD-1, for example. And this case is quite easy because this guy actually has a history of the same. It's the nodular lymphocytic predominant B lymphoma, B-cell lymphoma, previously called Hodgkin lymphoma, nodular lymphocyte predominant Hodgkin lymphoma, but the cells actually don't have very much in common with normal Hodgkin lymphoma, so now it should be called B-cell lymphoma. You see these malignant cells here as well, they are very large. You see my eyes now.
So this category of Hodgkin doesn't exist anymore.
Yeah, some people still call it Hodgkin lymphoma, but I was, last week I went to a course which was very focused on these, and all of the experts call it B-cell lymphoma. They have a complete B-cell program, they are positive for OCT2, CD20, CD79A, and they are negative for CD30 and CD15, which is otherwise typical for Hodgkin lymphoma. Yeah, and these nice rosettes, they are not only typical for this type of B-cell lymphoma, previously Hodgkin lymphoma, you can actually see these structures in normal classical Hodgkin lymphoma as well. That's all. Thank you.
Michael, the old one. We have here excision of the skin going out all the man. That looked like a plague, like scar, but this is an entity described in Friedrichshafen in 90s, and it's called dermatomyofibroma. After it was described under this, they call it originally plague-like fibromatosis, yeah, at the time. It describes the macroscopic feature of it, and I think the name of plague-like fibromatosis sounds a little bit better, but now it is renamed as dermatomyofibroma. It's perfectly benign lesion.
Yeah, last week they published PDGFB mutations in it, the same as are in myofibromas. So it might be related. Yeah.
Okay, here I have a lesion that was present in introitus of vagina. It was polypoid lesion, and diagnostic of that are these squamous-like islands that are fenestrated by adenomatous, benign-looking inclusions, yeah, and these inclusions are often prostatic markers positive. In this case, it was not the truth, but actually it is the first case where I didn't find prostatic specific antigen, yeah, but it doesn't require in 100% of the cases. This is called as adenosquamous polyp of vagina, and I think my son showed here very recently another case that was including prostatic marker positivity. The main pitfall is not to confuse it with dysplasia. It is P16 negative, and it's perfectly benign thing. Yeah, it sometimes is likened to prostatic positive scan glands, but I think this legend about scan glands is too vital to be crashed. But This doesn't have anything to see with scan glands. Just quite a lot of lesions, and we have maybe 20 of them in vulva and vagina are having glands that are prostatic markers positive. That means it's not that rare in women. Another case, I've shown several cases in the past, but this is a very nice instructive case. Pigmented lesion of the skin, and I think that without further examination, most people would call it malignant melanoma. It is ethanoate protein 6 that tyrosinase positive.
Is it BOP1 deficient?
Yes, but I have here BOP1, and we have now maybe one BOP1 deleted lesions every 10 days now. I don't know how it is possible. I've in between 2 more cases where I've seen in the last 2 weeks. Look how nicely many of these large cells are BOP1 negative. A residual pigmented lesions BOP1 positive. It was even in this case was mutated in genetics, so that we even found BOP1 mutation. But in many cases you do not find the BOP1 mutations. It is caused by some epigenetic changes, so that the most decisive in these lesions is immunohistochemistry. Yeah. Usually, it's called BOP1 deficient melanocytoma, and most of these lesions are benign, even if having such atypia. We are aware of very few cases. In our hands, we have only, I guess, 1 case that was BOP1 deleted melanoma that metastasized to regional lymph node. Yeah, soft tissue lesion of older man. We have maybe 10 of such cases in our files. And I think this type of lesion, it is ethanoate protein positive, SOX10 positive. I'm pretty sure that this is an entity. It is called, it falls into the group of epithelioid schwannomas, but I'm pretty sure that this is an entity. I'm sure it will have some recurrent aberration on genetic level, but it is not well known some. Sharon Weiss used to call this lesion as neuroblastoma-like benign schwannoma. It just shows how picturesque these lesions are. It looks like matchsticks having heads open to the periphery. It is one of those epithelioid schwannomas that are usually easy to say that they are benign. You often find EMA-positive perineurium around it. I didn't try it in this case, yeah. Here is pigmented lesion in the scalp of middle-aged woman.
On the scalp?
Yeah. Okay. It had all immunomarkers of pigmented lesion. That means it was ethanoate SOX10 HAB45 and tyrosinase positive. Yeah, very interesting was genetics. It was GNAS mutated on molecular genetics, and it had even third mutation. The third mutation, such pigmented lesions is very important for malignant lesions, but I think in this case it's obvious that the lesion is malignant. But the GNAS mutation says that these malignant lesions arose from cellular blue nevus. I have maybe even one more block for some residual. No, I don't really. Some residual cellular blue nevus was seen. In this place, you see just this pleomorphic pigmented lesion. And sometimes you can see quite well differentiated cerebral nevus with some atypia, and you cannot say whether it is malignant or not. And it's difficult to solve it if it does not have third mutation. Those having third mutations are usually diagnosed later as malignant melanomas. I will show you lesion of which I will show you cases in the future, because we are reviewing hundreds of nasal polypoid lesions, and we found that in nasal polypoid lesions there is very little thing so far. So I start with this most primitive diagnostical lesion. It is this one. There is nothing difficult in it, and it's called inverted type of papilloma. Some call it still Schneiderian papilloma. Most of these lesions are EGFR mutated, and around about 5% of these show malignancy. It is the type of papilloma that is most often malignant. Yeah, but in a WHO classification, in all publications, there are papillomas of nose divided just into 3 subtypes: inverted, classical, averted, and oncocytic. But we found that there is at least 10 or more subtypes of it. I will show you one example. It is another patient. I don't remember, and it's not important, the age and gender of it. And we found this. That means it had typical areas of inverted polyp, but in addition to here, yeah, in addition to inverted polyp, we found here ceremocenos hamartoma, but it's not all. Beside ceremocenos hamartoma, we found this proliferation of adenomatous structures that has morphology that is typical of tubulopapillary low-grade ceremocenos carcinoma of nasal cavity. And in spite of, here you see, it's undistinguishable from tubulopapillary squamous carcinoma. And we found first by immunohistochemistry First by immunohistochemistry, BRAF mutation, which is positive even in these areas that look like inverted papilloma. But we found the same V600E mutation by genetics. Yeah. We have now 4 cases of this occurrence. It has never been published. And BRAF is one of tubulopapillary low-grade cerebrospinal carcinoma can have many types of recurrent lesions, and BRAF is one of them. Yeah. Especially in BRAF is mutated in tubulopapillary carcinomas that are having double layered, including myopathy layer in it. Yeah. So we think that this type of polyp will be one subentity of these interesting lesions. We think that the malignity will be very low. It will be practically the same as that of inverted papilloma. Here is another, just to show you versatility and difference. Another case I saw a few days ago of nasal lesion. And it has some areas with ceremoceanous hamartoma, and those are typical glandular structures arising in ceremoceanous hamartoma, as you can see here. But in addition, we see here areas that look like inverted papilloma, but inside of inverted papillomas you see this mucinous differentiation, and I would even say mucinous adenoma-like proliferation. I still don't have genetics of these lesions, but we have several cases of this as well. Just to show you that there are not only 3 types of papillomas of nasal, there will be at least 10, maybe more of them. Here I have lesion of the skin. It's a very nice diagnosis made by my son. It's very circumscribed. It looks like something benign, but still not entirely. It's not. Okay. If it would be pigmented lesion, it would really cause differential diagnosis to melanoma. But there is no mitosis, not even normal mitosis, but then atypical mitosis. And it is said that the only marker in these lesions is CD138, which is otherwise plasma cell marker, but somehow apparently this lesion is always positive, as you see here. And the diagnosis of this is cellular neurothelioma. I still don't know what these lesions are. Yeah? I don't think so that they would be peripheral nerve sheath anything. Yeah? It's enigmatic lesions, and even in big series, the authors didn't find one specific type of nature of these. Here I have lesion of cervix. And I think this lesion is not that rare. You will see it more often. It's papillary, you see. In these lesions, very difficult to consider invasion or non-invasion because they grow papillary in the papillary way, and they are usually excised tangentially, so that you very rarely have low of the basic of the lesion. Yeah. If you do P16, it is usually negative, but if you do HPV, you would usually find HPV 6 or HPV 11. In this case, it was HPV 11 positive. Yeah. So these low risk HPV positive lesions are typical of those having papillary configurations. Sometimes they can be even atypical. You can then call them verrucous carcinomas. And very rarely they can cause even malignant lesion. Yeah. Still, the malignant lesion is P16 negative because the malignancy in these lesions are not taken by E8, E9 oncogene, which activates P16. The malignancy goes different ways. So, but it can even metastasize. We have only, I guess, 3 cases, as I remember, of these malignant low-risk HPV cases, but the truth is that very few times we did genetics in these lesions.
How do you differentiate this from condyloma?
Condyloma has the same HPV6, HPV11. I think condyloma is a part of the same process.
So how do you differentiate them?
No, it's just way of nomenclature. Yeah, you can call it condyloma maybe, yeah, if you would like to. But they are called various. They are called papilloma. They are called if they are atypia, they are called verrucous carcinoma. Condyloma with atypias or condyloma without atypias. You can call it as you want. Yeah. Usually, as in this case, it's benign. Even if you don't see the basic of it, and even if you cannot exclude the invasion, yeah, it is not usually invasive. It's usually a pushing border. It's nasopharyngeal lesion, amazing, interesting thing. And I still don't know what to think about it, neither does Alena. And what was at most interesting was first SILT mutation. And SILT mutation would say that this is something like membranous basal cell adenoma or carcinoma. But in addition to SILT mutation, this lesion is P16 genetically positive. That means this P16 genetic positivity would show, of course, they show it to be more as these, I don't know how they are called, HPV-driven adenocarcinoma with multiple differentiation. Yeah, it's question what was the driver thing in this case? Whether it was the HPV infections or whether it was the SILT mutation. SILT mutation, especially if it is germline mutated, these tumors are very typical of salivary glands. Yeah. The truth is that we have maybe 15 cases, I don't know, maybe Batsem knows it better. We never tried them on the P16 or on HPV. Maybe you'll be surprised to see more cases, to find more cases. You can try it if you want. Yeah. Yeah, and I have here amazing patient that we followed here for several years, 30 years ago. I found the material, so I take it out. We even published the case in Central Blood Fear Pathology. It was East German journal. And the patient had lymph nodes that were growing along the esophagus, mediastinum to the neck and up. finally the patient died, and in addition to that, the patient had monoclonal paraprotein in peripheral blood. And these clear cell proliferation here are CD31, CD20 positive. That means they are positive markers for dendritic cell proliferation, and it was the first case published of follicular dendritic cell sarcoma having intranuclear inclusions. Yeah, I do not see that. It would take me some time. Yeah, you will see them in the middle. You see, can you see these intranuclear inclusions above the middle? No, they're in the middle. Yeah. And these intranuclear inclusions are very typical of follicular dendritic cell sarcomas. Yeah. And this paraprotein, we found that plasmacytic proliferation in this case was having monoclonal restrictions. It was lambda positive. And it's quite often seen in follicular dendritic cell sarcoma that there is some lymphoid proliferation in addition to this malignant lesion. It was at a time when it was published in 1993, 32 years ago. It was at a time when this entity was entirely unrecognized, and many people said that didn't exist. There was only one paper of Rosai and Mondo. They published 4 cases of it, and they were the first one saying it exists. Yeah, all the rest of the papers by Fletcher and Warnke, and they followed these publications. We have just 2 minutes. I would like to inform you that we had a very interesting sitting yesterday with the owner of company named AIXMed. It is a company from Taiwan. They have laboratory in Taiwan and a seat in the United States. That means in the United States as well. And they have prepared programs for reading urological cytology and thyroid cytology by artificial intelligence, so that we will adopt these programs as first. And for next year, they prepare a program for reading cytology of lungs. Yeah. So we will, and Dr. Sulečko from our laboratory and our ITs tried already this program, and it really looks very promising. It will be nice shift in forward because we do nearly 3,000 urological samples a year. I'm sure that many urologists would take more of these samples if they know we could give them more information than from just normal ocometric, we check English, idiotic name, imetric diagnosis. Okay, thank you for your attention.
Thank you.